Good evening, Part 1 aspirants and our honorable faculty. Today's the class is about acute renal failure, which would be conducted by Dr. Neeraj Kumar. He is an associate professor, anesthesiologist at AIIMS, PATNA. His area of interest are as follows: critical care medicine, neurocritical care, and trauma critical care.
Good evening to all of you. Today I'm going to speak on AKI, especially about acute kidney. Before that, you must understand the concept that why this AKI is very important, because these AKI, especially in critically ill patients, if you are not going to manage it properly, these patients have a very long-term morbidity and mortality, and these patients are always at risk. So as per the current diagnostic criteria, it is very important to closely monitor these patients. And since the current diagnostic criteria may result in late recognition, so there are various development in these diagnostic criteria, like previously the rifle criteria was there, then later on the ACIN criteria was there, then your kidney disease global outcome was there. So if apart from that, there are various biomarkers also which assist in earlier diagnosis of these acute kidney injury, especially in ICU patients. And third, most important is the optimization of your hemodynamics, which includes that early appropriate antibiotic therapy. And then as most frequently, the nephrologist would able to write about the avoidance of nephrotoxic drugs or substances, because these are most important for creating those, you say that acute kidney injury. And later on, they may convert, it may be AKI may be an important risk factors for development of chronic kidney disease and later on end-stage renal disease. So before that, it's very important that why these acute kidney injury is very important. If you see the exact pathogenesis or pathophysiology, you will understand there are several cascades. Not at the level of only complement system and coagulation activation, but even at the cellular level, these injuries can happen. So if you concentrate on these microbial insert, the patient, after getting those microbial insert, either in the form of endotoxin, LPS, like 𝐷𝒓𝒆𝒑, or if these patients underwent into a pro-inflammatory state. So it could be free radical formation, it could be cytokine secretion or release, it could be at cellular involvement. So here, the more and more neutrophils, macrophages, and endothelial activation would be there. If you look about the protease activation, so again, it is very important because heparan sulfate and your elastase, it's a very, very important protease marker that elevates as a pro-inflammatory state. And later on, the second part, if you concentrate your anti-inflammatory state. So it has all points of anti-inflammatory state, like this patient will have, these patients may have increased interleukin 10, poor phagocytosis, then these patients may have deranged immune function, impaired chemotaxis, and later on, all the problems like oliguria, impaired vascular tone, capillary release, apoptosis, endothelial dysfunction, metabolic acidosis, all can cause multi-organ failure and death. That's why these AKI is very, very important, because it involves entire pro-inflammatory state as well as your anti-inflammatory state. Both get disturbed, leading to your all those important pathophysiology like thrombosis and endothelial dysfunction. So not going further details, but if you see this slide, that this acute kidney injury doesn't invariably present with oliguria, right? So what will happen? Why? Because if you focus on non-oliguric AKI, it occurs in 28 to 45% of the general ICU population, but it may be up to 50% depending upon the definition what we are using for labeling these as a AKI. So these non-oliguric AKI always has a better prognosis. And even one study was published in Nephroclinical Care Practice in 2005, which suggested that this non-oliguric area, the AKI, was associated with a higher in-hospital mortality. So the thoughts was different. So always it is important to identify a non-oliguric AKI. Similarly, now a question is there that how do we recognize and resuscitate the oliguric or anuric patient? So the steps, if you look, first of all, your rifle criteria, the initial rifle criteria that was that was being started in 2004 based on the urinary output. So now again, this is very important for EDIC Part 1 point of view as a questions like type A or type K questions, that they used to ask each and every points of those rifle criteria. They want to test whether you are knowing the exact definition of those rifle criteria or gradings of R, I, F, L, and E. So it is always based on the type of urine, the amount of the urine output as well as duration of hours. So must remember that these durations should be more than 6 hours and urine output should be less than 0.5 ml per kg body weight per hour. But it was introduced as an alternative criteria, and then later on, rise in serum creatinine 1.5% from the baseline were also included. This definition in the 2004 later it was further modified by a group of AKI network, and then a ACHIN classification was developed in 2007. But if you'll see that in 2012, the 𝐄𝐃𝐈𝒂 classification came into a practice in which kidney disease improving global outcome was there in classification. If you'll see that rifle criteria, they have divided this R, I, F, L, and E. So what is R? If it should be based on urine output, so it should be always 6 hours duration, always 12 hour duration for determining injury, always more than 12-hour duration with anuria, and more than 24 hours duration with urine output of less than 0.3. So we used to remember like that, 0.5, 0.5, and then 0.3. So 0.5 is 612, and then 0.3 is 24. If patient is anuric, then you add 24. So it is the definition of oliguria. So based on urine output, but later on, this was based on serum creatinine also. So it was 1.5, 2, and 3. So 1.2, 1.5 from the baseline, 2 from the baseline, and then increase creatinine multiplied by 3 of baseline creatinine. It means if from injury to failure, if you want to see, so what was the acute rise in your creatinine? The acute rise must be more than 0.5 milligram per day. So it was a definition based on serum creatinine criteria and then based on urine output. Then the last two word, that is loss and is ESKD or end-stage renal disease, that has been defined by persistent AKI. What do you mean by persistent AKI? Persistent AKI means if the patient has loss of renal function for more than 28 days. So it was defined as loss. And what was ESKD? The patient underwent into an end-stage renal disease. So if you compare the two criteria like rifle and ACHIN, similarly, you see there are very minute difference between rifle and ACHIN. But in EDIC exam, they used to ask ACHIN as well as rifle, and they will give you the options like that. So if the patient is in stage 1 ACHIN, what do you feel? If a patient is in stage 1 ACHIN, it means serum creatinine has increased from more than 0.3 milligram per DL or increase in 1.5 to 2-fold from the baseline. Okay, and the urine output is less than 0.5 kg per kg body weight per hour for 6 hours. It is exactly the similarly what the rifle of R says. But in rifle of R says, they have also included the GFR, that is decrease in the GFR for more than 25%, decrease in GFR for more than 50%, and decrease in GFR for more than 75% from the baseline GFR. So they have classified it as R, I, and F. Similarly, if you see that if the patient is in stage 3 ACHIN criteria, so what does it mean? Stage 3 means the creatinine has increased to 3-fold. What do you mean by 3-fold? It means the creatinine is more than 4 milligram per DL with an acute increase in 0.5 milligram per DL. So it is always important. And then I also ask you to remember like that 0.3 more than 24 hours, anuria for 12 hours. So this is the major difference that they used to ask in the exam, that what do you mean by ACHIN stage 3? What do you mean by rifle class R? Or how will you define rifle R based on 2 hours, 4 hours, 6 hours, or based on 24 hours, 48 hours, like that? They will ask, or they will give a scenario that the patient, if the serum creatinine from if the serum creatinine, initial serum creatinine was 2.5 and then it was increased to 5 milligram per DL. So what was the class that has been changed? So the class may be changed from 2 to a stage 3, but here the important is what was the acute rise in that creatinine. And then stage 3, the need for RRT arises. Now coming to that is what I have already mentioned, that detection of urine flow less than 0.5 ml per kg body weight per hour for 6 consecutive hours. So it is very important that as soon as you detect oliguria, to identify it as a pre-renal failure, It may be progress to ATN very rapidly if you are not going to treat it very promptly. If you're not prompt, that it may land up, your patient from pre-renal may land up in your ATN. So anuria less than 50 ml per day urine, it basically represent a late stage of pre-renal failure. And rifle criteria, I already signifies the duration of more than 6 hours, 12 hours, and 24 hours. So that's why the greater the duration of oliguria, increasing the rifle class, the greater the severity and greater the hospital mortality. So maybe sometimes they used to ask that what this rifle criteria usually signifies. It signifies the severity of your renal injury as well as hospital mortality. Now, based on your again a classification was there in which the 16th acute dialysis quality initiative consensus conference was held, and they defined as 3 different terms like that. What do you mean by recovery of AKI? How you'll say that your patient is recovered from AKI? So it should be based on the absence of creatinine and urine output criteria within 7 days after AKI onset. So if the creatinine or if the urine output remain going to become neutral or normal range within 7 days after AKI onset, so you can label it as a recovery of AKI. And if recoveries occur within 48 hours of the onset, it is referred as rapid reversal. Basically, these are few terms that you used to know, that what do you mean by rapid reversal, what do you mean by recovery of AKI, and what do you mean by AKD, acute kidney disease. So when you will say that your patient is having not an AKI, acute kidney disease. So if your AKI persisting at day 7, if it persists at day 7, it is known as acute kidney disease. At many places, the AKD has been used. So if AKD has been used, you have to understand you have to make a concept that, okay, in this patient, if the patient is having acute kidney disease, the AKI must have persisted for till day 7. And if AKD persisted on till day 19, it becomes a chronic kidney disease. So there is a very simple difference based on the duration of the duration. If it is 90, chronic kidney disease. If AKI 7 days, AKD. Now, again, because these are all fact-based things, so because in type K question, they will test like that. Everything they will test. What is the definition of uremia? They will ask. What is the definition of azotemia? They will ask. Single options. Similarly, based on the time, the classification has been made into pre-renal, renal, and post-renal. So if you focus on the pre-renal, what is the exact pathophysiology? So decrease in the cardiac output, because these patients may have a hypotension, hypovolemia. So these hypovolemia, septicemia, all these can cause a pre-renal stage or excessive dehydration, excessive hemorrhage or hemorrhagic loss. Or because what will happen in these kinds of patients, they have a sympathetic nervous system stimulation because of vasoconstriction and decrease cardiac output, leading to pre-renal failure. And what will be the factor? Very lesser common factor, mispositioning of the aortic device. It has been written, but there are many other iatrogenic factors. But if you'll see that what would be the cause for intrinsic renal failure or your acute tubular necrosis, that the cause would be, again, here the cause is your RAS activation. And here the nephrotoxic contrast agents or one non-fondaparinux parenteral anticoagulant may be a cause, but nephronic contrast agents and various drugs, nephrotoxic drugs here, which is responsible for your interstitial nephritis or acute tubular necrosis or intrinsic renal failure, because the pathophysiology is your RAS activation. But if you focus or concentrate on the post-renal causes, it's very important that in these patients, there is a systemic congestion leading to increased central venous pressure. Why it is so? Because of the obstruction. Because pre-renal means outside the renal, renal means inside the renal, and post-renal beyond the renal. So always think of the cause like urethra, like bladder outlet obstruction. So it may be because of excess intrathoracic pressure during mechanical ventilation. Again, you have to think for the cause of post-renal failure. Similarly, if you'll further focus on various other pathophysiology, like first I told you about the volume depletion, then systemic vasodilatation, and then your intrarenal vasoconstriction. Basically, it is sympathetic nervous system stimulated based. That's why hemodynamically mediated is. How will you diagnose? Based on your history, based on your urine analysis. And I will not focus on management part because it has been dealt separately. Yeah, it has been taken from a chest. That's why I have quoted here. So intrinsic causes, so all glomerular, if the injury is persisting to glomerulus, so it will be your intrinsic damage. So maybe eosinophils, maybe white blood cells on urine examination or your urine analysis, maybe tubular because of tubular cell cast, or maybe vascular. So how are you going to diagnose? So all intrinsic renal failure patient, intrinsic AKI, it should be diagnosed using your USG, like renal ultrasound, urine analysis, and your renal biopsy. So always important that here, if you not manage this pre-renal, it will land up into intrinsic renal failure. And here the toxic drug roles a very important role to play. Similarly, the post-renal patients, they have mostly obstruction to urine outflow. Maybe the cause may be the extra-renal one because of the prostate hypertrophy, prostate malignancy, urinary tract malignancy, maybe RPF, retroperitoneal fibrosis, maybe because of intra-renal like stones, crystals, or tumor. So here the diagnosis would be made only based on your renal ultrasonography and management. Yes, I will deal the management also one by one. Like what do you mean by percutaneous drainage, the stenting, catheterization, everything is important. Now coming to so why this pre-renal? Again, if you have been asked about the question that which is the most common cause of renal failure for amongst hospitalized patients, so always pre-renal failure or azotemia top the list. Already I've discussed about the indication, like history of high output GI losses, like dehydration, diarrhea, hemorrhage, or because of trauma, because of any vascular injuries like sepsis, congestive heart failure, or if the patient has a decreased oral intake, if more than 10 to 15% of circulatory volume is lost, then these patients may have hypotension. So here, if you'll examine, the patient may give options like the patient have a hypotension, they have a very low CVP, they may have oliguric, they may have altered mentation, they may have tachycardia, they may have cold clammy skin with very delayed CFT. Capillary filling time will be very, very delayed. And if you'll talk about the renal, again, the CVP in cases of renal as well as in post-renal, the CVP may be increased. Now, intrinsic causes, yes, in cases of ICU, pre-renal failure is the most common diagnosis because the hypovolemia and sepsis. And here, the failure of hemodynamic restoration because of the fluid replacement to restore the urine output and the exclusion of the post-renal pathology always support the diagnosis of pre-renal failure. And then allergic interstitial nephritis because of the antibiotics may be responsible for your intrinsic renal failure. Then post-renal failure, it accounts for less than 5% of the cases of the AKI, mostly because of the urinary tract obstruction. I already discussed about the hypertrophy, neoplasia, and infection of the prostatic disease. Even few patients may have neurogenic bladder that results to post-renal failure. If you're treating your patient with anticholinergic drug, again, the chances of post-renal failure will be more. Yeah, few of the less common cause, I already talked about blood clots, calculi, and urethritis with spasm can lead to ATI like Lutz, lower urinary tract obstruction, or that lead to a post-obstruction or post-renal failure. Similarly, a term that is persistent severe oliguria or anuria, if it is lasting for several weeks, always it creates a suspicion of severe acute tubular necrosis because 5% of the survivors do not recover from renal function or because of the cortical necrosis. Classically, the severe or because of prolonged hypoperfusion, it results in very patchy focal tubular damage, which includes cortical necrosis or cortical apoptosis of the tubular cells. That results in severe, persistent severe oliguria. So you may be asked that if persistent severe oliguria is there, so what will be the pathophysiology? So these patients have patchy focal tubular damage because of the necrosis and because of the apoptosis. Coming to the resuscitation part, that all these oliguric, because I talked about non-oliguric patients, non-oliguric patients are more in number, but if you'll not manage it properly, it may land up in oliguric renal failure. And these oliguric patients, mostly the cause would be pre-renal failure, like 55 to 90% patients. So what is there? So a broad consensus was there to provide acute resuscitation in form of fluid therapy. So many patients presume that these renal oliguria have a ischemic. May these patients have ischemic hypoperfusion and that's why a trial of expansion of giving more and more fluid and to increasing the circulatory volume has been warranted. And even only to avoid unnecessary aggravation of the renal insult due to uncorrected hypoperfusion. So a concept was there that it should be presumed that renal oliguria may be due to your ischemic hypoperfusion. Similarly, in resuscitation part, the concept of end-point resuscitation or fluid resuscitation was named as fluid challenge. Why? Because you have to give the fluid early and then targeted based on your various hemodynamic endpoints. So there is long list like increase in MAP, plus by looking for the pulse pressure variation, by looking for the cardiac output, by seeing the central venous pressure, by seeing the central venous oxygen saturation, and then urine output, and then improvement in the lactic acidosis, leading to your skin perfusion. So all those important hemodynamic endpoints while you are attempting a fluid challenge. Now you see that a classification was suggested by Vincent and Weil. What he found that they have suggested a protocol for fluid challenge, which include the four variation like type of fluid administered, rate of fluid administration, critical endpoints, and then safety limits. So what they found that if you are going to give early fluid therapy, okay, if you are going to give an early fluid therapy, like inotropic support, where the inotropic support was also necessary, and on targeting the endpoints, it was seen that greater increase in urine output, great improvement in central venous pressure and arterial pressure significantly reduce the mortality. In which group of patient? In patient with severe sepsis or septic shock, especially in accident and emergency cases. So what they found, if you follow these Vincent and Weil protocol of type of fluid, rate of fluid, and critical endpoints and safety limits, you may have a reduced mortality, and it was statistically significant.